the issue of adenomyosis and pre-treatment with agonists, and that goes also into uterine contraction.
If the GnRH analogs prior to the frozen transfer. So, but you're, I mean, first you have to figure out how to measure the contractility, then we can really explore if it's increased in certain groups. But I also had a question. You're looking at the day of the transfer. You don't want to look the day before the transfer. That maybe you can intervene prior to the transfer. Yeah. Yeah. Very interesting. Yeah, we have assessed several patients 2 days before, 3 days before, even 1 day after. Once we start with the progesterone and the progesterone reaches the level, we don't have differences with the uterine contractions. So we have theoretically we have the same contractions day before, day after, or even 2 days before, if the progesterone, because the most the association is with progesterone for sure. The problem is we are still seeing compressions not associated with progesterone. Right. And like you said, the tissue, like if you're using vaginal progesterone versus IM progesterone, you may have different levels in the blood, but the tissue levels are maybe the same. Yeah. Yeah, I think because what the problem is I cannot demonstrate it, but what I see is that when I have contractions because the progesterone levels are low, and the contractions are more coordinated. Like higher frequency, but like 2, 3. When you have the another contractions, it's more like next. It's like, confidence. And, probably this is something, but how to measure that? Because, it's only me seeing that, and okay, I see that. But, well, retrospectively, we looked at several hundred patients in the new practice where I am now that looked at contractility the day before the transfer, and then they would give an extra progesterone dose the day before the transfer, and then the results were the same in terms of outcomes. But we did not see correlation with the progesterone levels. We had like 40, I don't know what your percentage, we had like 43% of the patients do have uterine contractility, and they got an extra iron dose just that one time the day before the transfer. This program is pretty aggressive, giving 75 milligrams IM a day and then an extra dose. But didn't look to follow up with contractility changes. Yeah, but because it wasn't, I didn't see it. Yeah, and I didn't see it. However, look, my patients are relevant, but these failure patients. They have the low progesterone levels is not the low progesterone levels that you think. It's they usually by our protocol they are using more than 800 progesterone vaginally and then subcutaneously probably one shot or two. So it's not a matter of how the dosage of progesterone, but it's true that you can see constantly, because every time that I'm adding information constantly, I can see the progesterone association with contractions. And that's why I encourage him to continue, because anyway, I will look it down, because it's true that it's a subjective count, but I do believe that we are doing something good. And I think really that I'm improving some. Okay, let's start. I only see around 30% of our patients have contractions, and around 65%, I think, was associated with low progesterone levels. Okay, and what we see in another study is, because we treat them, we have better pregnancy rate in patients with contractions, because we see the contractions and probably we are solving it. I'm sure of that. I cannot demonstrate it. It's a retrospective study. So, but really, I do believe that I'm doing something good. That's why I'm encouraging.
So, Belen, all of your patients are recurrent implantation patients. Don't you think it would be interesting to study like basal state in normal, none of our patients is normal.
Yeah, because the first randomized trial, when we assessed the contractions, as I told you, was the comparison of two progesterone, subcutaneous and vaginal, and it turned out that the progesterone, the subcutaneous, it was only one shot and it wasn't enough. And that's why we have the continuation now with 2 injections, comparison with the vaginal progesterone, and we are assessing again the contraction. So we are in this randomized trial assessing baseline patients without recurrent implantation failure. But probably I'm feeling better assessing recurrent implantation failure, to be honest. Because I think really that I can see this risk factor. And I do believe that if you treat with more progesterone, you are treating actually with more progesterone, because you are assessing progesterone levels. But if you are treating with the first shot of atosiban, you are not doing anything wrong. Even studies that can improve the pregnancy rate. So at least we are selecting the people that need good treatment.
Yeah, no, I agree with you, and those are the patients that need it. But thinking about your question about how to measure, what's the best way to be able to assess in 4D all of the uterus and the individual. That's why I wanted Peter to be there. So I think
it's very good. First of all, I would really like to thank you for your passion and your presentation, because what you show is not only the future, because it's already there. And I can assure you, but I cannot tell it now in the audience, because it's a big focus from us, from focus from you know. Because the contractility, you know that also in the fetal heart, there is a lot of focus on the contractility of the fetal heart, so contractility is measurable. But now, of course, we need to find a way of to do it in the images that you show. Because at the moment, is what you do now is with your coronal plane, that you see it so fantastically in all the directions that you can see. And to be honest, that's also contractility what you see in the fetal heart. So, but it's really a focus from our side that I cannot get into more details.
I can.
Yeah, you can, but okay.
Yeah, I was literally obsessed from, I think, that summer. And, I know that exists already the CNN, and there are nets that are accessing the 4D CT, like the QI. So, I need it.
No, it's what I can say. It's a big focus, but there is a lot of engineering work that needs to be done. And you know, but also what you said, it's so fantastic to see these images, and also it started, for example. Of course, I'm going back again to the control, but you have the images now, and oh, it's nice, but now you need to make it measurable. Because without the number, of course, measurements, it's always the key, and you need to have an easy measurement. Yeah, and that's where we need to focus on. And I can tell you, we are focusing on this, but it's too much information. I cannot, engineering level, I cannot.
Anyway, my problem always is the measurements. Everybody's doing it to be, and what I see constantly again is that I cannot see really any objective association.
No, exactly, because you also show the images with elastography, but that's also very difficult to measure. And also the spectral tracking, so where do you place the box and where do you place the vector, and what kind of vector do you have in the spectral tracking? Because we know there are different vectors that they can play, but we need to, together with you and the research team, we need to continue on this one. Then you need to have the right measurements. Because a measurement, especially in your work, a measurement should be easy to do. And of course, in the research level, then of course we can ask, okay, can you try this, but the measurement in the daily work with all the patients and with the patient flow should just be a kind of click of a button, isn't it? But there is a focus, but that's what I can say.
Okay.
Otherwise, you all have to sign a non-disclosure agreement.
Yeah, we have a question there.
Hi, can you please tell me when would you choose to use Atosiban? Well, we saw in very interesting way the article published in 2019 in which they treated the Atosiban with the first treatment. You know that there are a first treatment and then a continuous bond. So the first treatment was in this randomized controlled trial in endometriosis, and they improved the pregnancy rate. So we thought that, okay, we can start with that because we thought that really we needed to treat these patients with hypercontractility and with normal levels of progesterone, you know. And yeah, finally, I cannot demonstrate it, but our feelings and the numbers is true that we have better pregnancy rate. But the problem is that turns out that it seems that the opposite, that higher contractility achieves better pregnancy rate in patients, you know, and it's difficult to measure what is the change here. That's why we published in a poster here in a national congress, I think, but we cannot demonstrate it. But we really are carrying with this strategy. Probably we have better strategies because, you know, the invasion trophoblast has an important role during the contractions, has an important role there. And even when I saw that we have more contractions in substitute cycles, I thought, okay, the people are telling me that now in natural cycles we have less preeclampsia, the babies are bigger, all because the lutein purpose, and not because that we have less contractions. And the invasion is important, even more with preeclampsias and all this, no? So that's why I think we need to treat them in some way. I'm not sure if it's the best way, but it's difficult. First, we need to establish what's the contractions probably, and we need to make more research. But I would like to encourage you to do 4D because really I think 2D is not enough.
I just want to say, I'm sorry to interrupt, but we are quite late and we do have, we have to go to the coffee break for just 5 minutes because we're late. And then we will have a final discussion for more questions. So I think it's better if we start this discussion